I guess what I'm thinking of is with all these attempts to change the alpha synuclein back into a normal form. First of all, is that a protein that is the same across the board in everyone, or is it different?
So, so as I mentioned, in a few patients, there are mutations, real changes in that gene that cause early onset neurologic disease. Most people have what we call the wild type or the normal version of that protein, and it is in MSA and in most cases of Parkinson's disease, it is the wild type or the normal form of that protein that aggregates, forms those abnormal accumulations. So yes, for most people, it is the same protein that is aggregating.
Okay, now you confused me. You're saying the wild type is the mutated one?
No, the wild type means normal.
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 But that's the one that aggregates and causes problems?
In the vast majority of patients with Parkinson's disease and in all patients with MSA, it is that normal form that causes the aggregation. So it's not a change in the protein itself, but the protein is doing something abnormal. Okay, so the aggregation of that protein is not what you would see in a person's brain who does not have the disease, but the sequence of the protein. It's like if we arranged a protein sequence in a bunch of letters, that the sequence is okay. It's just folding in the wrong way, and it's causing problems in the way it folds, and that problem in folding is then causing other problems in the nerve cells in which that aggregation is occurring.
Would this be identifiable to, say, a system like an enzyme that could recognize that it is aberrant and could attack it and destroy it?
So one of the more promising things that's being tested in that kind of line of thinking is that we know that this protein, when it aggregates, it spreads to other cells and it causes the protein in those other cells to also aggregate. And so one of the things that's been trying, and I think it's very interesting, is to use antibodies that prevent the spread of that protein from one cell to another. And so that is a very active area of research right now, and that's the kind of thing you're talking about, where we can design an antibody to target that protein. The problem is, of course, that the process of doing that may also be a normal process that the brain needs, and we don't know what the potential side effects of that kind of treatment are. But it's a very active area of research.
Thank you.
You know, I would add, I'd be arrogant enough to add the comment to Dr. Kurana, who's the real expert on synuclein. But you know, what you said is very important, because your apparent confusion initially got a lot of people confused in science. Why? You see, there was a scientist called Polymeropoulos that first described that a mutation, what Dr. Kurana showed, a mutation in the signal of this protein called synuclein caused a familial form of Parkinson's disease. He described a family with a mutation in the gene that produced an abnormal type of synuclein, a mutated synuclein, and that mutated protein accumulated abnormally and killed the neurons. That was a big revolution. A few months later, it was found that the same protein, without mutation, the normal wild protein, was also being deposited in people with garden variety Parkinson's disease, not with the genetic form. So that was a huge revolution, because it was not just the mutated protein, it was something about that protein, even when it was normal, that did not fold properly and accumulated. And that happened in Parkinson's. A few months later, it was found that not just in the Lewy body of Parkinson's, but in the neurons of people with MSA, same story, synuclein also. A few months later, we published that in pure autonomic failure, a disease without CNS symptoms, without motor problems, in the periphery, in the nerves outside the brain, the deposits that were destroying those neurons were also the same protein, synuclein, which was not mutated, was the normal garden variety synuclein. So this protein is mutated or non-mutated is really a problem. And then there are patients that have what's called a triplication. Instead of having 2 genes, they have 3 genes that produce this synuclein, so produce a lot, and those guys also develop Parkinson's. So the story is a fascinating one. And the next point of the story that maybe next year we'll talk about is the possibility that this is a prion disease. That in some way synuclein, because now you inject synuclein in a mice, you may, from a patient with MSA, you can produce lesions in the mice. You inject that protein from the brain of a patient in a mice, you produce a mice with MSA. So this is like a contagious thing, but in this interesting story, which is the prion disease, for which there's a guy that got the Nobel Prize for that. This is like mad cow disease or Creutzfeldt-Jakob. Is a different story, but maybe the mechanism of reproduction is similar, and we hope that it's the guys like Kurana that's going to give us the answer by studying this in a petri dish and advancing that, what happens with that protein, okay?
Thank you. I have one here that's going to be hopefully a really quick answer. This one is for Dr. Norcliffe Kaufman. How will the data for the Gossamer Registry be collected? Is it the patient the source, or is the neurologist the source?
That's an excellent question. We believe that some of the data can be filled by the patients themselves, like contact information and when they were diagnosed with the disease, because the patients obviously carry those answers. But we believe some of the more formal medical measurements will need to be filled by a qualified person that is trained in filling the scales, that understands the vocabulary. So we have many steps to do in order to be able to standardize how this data is collected, but the answer is it will probably be a mixture.
Yeah, so we have a question here, maybe to the MSA Coalition and everybody. Is there a place where MSA patients can make arrangements for brain donation?
Yeah.
Anyone
Okay, I'll
connected?
take
If
the,
not-
you heard Dr. Kurana that of course MGH wants them. I can tell you that
I think that's what prompted the question. So
Correct.
now how do they
Yeah,
go about making those arrangements?
you know, MGH wants them, NYU wants them, Vanderbilt wants them, everybody wants them. So I tell you that, and they can also answer, you could contact either the consortium or any of these institutions, and there's paperwork that you can fill and sign that will allow brain donation. And there is a system, I tell you, the system we have at NYU, I presume at Massachusetts General is the same story. There's a 24-hour, 7 days a week service that is based on the Alzheimer's brain bank. So we share the resources. There's a person with a beeper on call, 24 hours that switches. So if somebody is very sick or believes that this is is going to die, things are arranged to do that. Maybe you could
There's also a lady named Robin Riddle who has taken upon herself to help families arrange brain donation. And she has a website called brainsupportnetwork.org, I think. So if you look that up, or it's also in our brochures, okay. So you can contact her for some information.
There is, I'm taking one here that says, how does MSA affect the eyes? Okay, I like this question because we are working on that. Interestingly, a lot of people with Parkinson's complain of eye problems. people with MSA usually don't complain of eye problems, with color or any of the other, or even visual acuity. There are usually no clear-cut abnormalities. However, we did look at the retina. The retina is the front of the optic nerve, and these are the only neurons that you can actually see without opening the brain, opening the head, which most people don't like to have done. But then there's a machine called OCT, or optic coherence tomography, where you can look at the retina and actually measure the thickness of each of the neuronal layers. And what we found is that in people with MSA, there is a reduction in some areas. They get much thinner, the retina gets much thinner, and we hope, we just sent this out for publication in actually it was 25 patients. Let me digress for a second. Neuro-ophthalmologists, when you study 25 patients, they tell you, you didn't study 25 patients, you study 50 eyes. So I thought, well, that's a great way to put things. So the study is on 50 eyes, not 25 people. So what we saw is that the thickness of the retinal nerve fiber layer, it gets progressively thinner with time in MSA, and we hope that this is going to be a biomarker, that this will allow us to maybe follow the progression of the disease with an objective measurement. What you heard in the talks, the need for biomarkers for clinical trials, we hope that perhaps this measurement in the retina will be useful, and it's better than MRIs because the resolution is much better. The resolution of MRI is 1 millimeter. The resolution of the OCT is 1/10 of that. So any neuronal changes that occur, very small changes, we may detect them in the retina way before we do it in the rest of the brain. And of course, the retina is part of the central nervous system. The other part of the eye that is very affected in MSA is what we call the efferent part, meaning the eye movements. The eye movements, the ability to move the eyes one side or the other, that's very affected in MSA. That's why people have these jerky movements, or what's called nystagmus, or other abnormalities of eye movements. But visual acuity doesn't seem to, or color vision is not affected. Despite that, it gets progressively thin.
We got a very interesting question from the web, which is, we were always told MSA is so rare. Yet in our village of 110 houses, my husband is the third case in 5 years. Shouldn't somebody be looking at this? My short answer to this question is definitely. I think that this is something that is potentially very interesting and we could learn a lot from.
What we don't know is the name of the village. Maybe it's MSAville, right?
I think in regard to the last question as well, if it is a number that's unusual, it's important to have people accurately diagnosed, just to make sure that it is that disease. Sometimes there are difficulties in diagnosis. I'll take a question here. One question I have is that I know stem cell research is being done. Is it any help that I saved my 3 daughters' stem cells at birth? Is it helpful, or does it not matter at all? And I assume that that's from umbilical cord blood. And then the question is, is that helpful? I would say that just as those mesenchymal cells I was telling you about for the trial that's been done in Korea, cord blood is also a very interesting group of cells that not only can regenerate different tissues but can secrete interesting factors. I think it's up in the air, just as it is for mesenchymal stem cells. What we need to do is understand what are these factors that are coming out of these cells, how do they work, and how do they affect the pathology in these diseases. And if we have some logical answers to those questions, then we can address better what we can do with stem cells. So the answer is it potentially may be helpful, but we can also generate stem cells a patient themselves now, and so whether one needs cord blood for certain things that one can't do through other methods is really an open question. But I would say we don't have the definitive answer to that, but we need to do more work.
We have a person here that wants to ask a question.
Hi. Regarding blood pressure, if an MSA patient has extremely low pressure but no symptoms, should that be a concern, or should they do something to try to elevate it?
Excellent issue that we see every day. If there are no symptoms of low blood pressure, we are not aware yet that treating that has any use. So what we saw is that usually, I would say more than usually, almost 100% of the cases, if the blood pressure standing is below a mean of 75, that's a systolic of around 90, in the mid-90s, if it's below that, most likely there are going to be symptoms, and the symptoms can be explained by the low pressure. So low pressure with symptoms should be treated, without symptoms should not. And in fact, the approval of these drugs we were talking about is for symptomatic orthostatic hypotension or neurogenic OH. It's not for the asymptomatic one. The asymptomatic one maybe it will become symptomatic, but if it's not symptomatic, we have no data saying that treating it is the case. It's important to realize, I don't want to belittle the fact, but it's important to realize that what may appear asymptomatic in the office may be symptomatic at home, let's say after meals, or when the weather is warm, meaning somebody can tell you in the office no symptoms, but then at home after a meal or when straining, there may be symptoms. So if you confirm that there are symptoms, you treat. If there are no symptoms, no treatment.
Thank you.
Okay, we have a couple questions related to vocal cords and voice in MSA, so I would welcome all your contributions here if we can answer that. So the first one is there any success with using Botox to pump up the vocal cords, I suppose, or strengthening the voice? So we generally use Botox when the voice problem is a form of dystonia. I'm not aware that this is the case in MSA, but maybe we have a different opinions here.
No, I think you're right, Kemal. In fact, we published this like 20 years ago, showing that the alterations in the vocal cords in MSA may not be directly what we call the lower motor neuron nerves, but it's the connections from the brain that alter the vocal cords. Usually, Botox is not very effective, but in some cases it may be. What happens in MSA is that there is a paralysis of the vocal cords, so they do not open properly, and that's why there is that sound that we call stridor. So Botox rarely works for that, but it's important that you may need to see an ENT person and actually look at the vocal cords directly and see if there is something to do, right? I have a few other questions, but...
Yeah, let's take the question from the public and then we'll go.
Yes, I had a question related to some of the questions that come across my caregiver representative page and that were brought up a bit, I think, from some of the comments you made. I think Dr. Khurana said that we really need to have, or we need to consider a longitudinal development of MSA. How does MSA start? Karen Thomas says we don't know where it starts, and it seems like there's, as yet, no way to determine how that progression occurs and in what degree each step of the symptomatology occurs. And so I've been, just over my time researching, and probably others as well, seems like the UMSARS is one approach that has some ability to give us a longitudinal story. Tremors, according to Dr. Wenning, seems to have some way of telling us. one of you had up there that Dr. Freeman had correspond or worked with you on an article, and we just recently read one of his where he found alpha-synuclein in the nerve cells within the skin. And then you were just talking about retina degeneration. It would seem to me that's one of the keys to solving this issue. Is any of those four, or is there another approach that people are looking at that would give us a longitudinal progression so we could kind of see how this symptom gets worse, how this symptom progresses, et cetera? Is that possible, or are any of these ready yet?
Look, you're absolutely right that that's the $64,000 question, is how do we measure disease progression, and so that when we are using a drug in a clinical trial, we can see whether the drug is working or is not working within a relatively short time, in a year or 2 years, because there is variability of the disease. So the approaches you mentioned are the common approaches. One are the clinic, like the UMSARS, right, which is a scale that measures how you move, the ability of doing things, and then you do a composite score, like we did with the orthostatic symptoms, or these are classic ways, subjective ways. Of course, it's available, but they are crude. They are crude ways to measure progression. We need better things. So the eye, as I was telling you, is a search for that. We don't know if it's going to pan out, but it may be one of them. The possibility, what Freeman mentioned, of measuring it in the skin, in MSA, that has not been validated. Yes, we are using that in Parkinson's, but maybe there may be a story there. MRIs, what's called volumetric magnetic resonance imaging, are also used with that goal, to measure areas, nuclei of the brain, and see how they shrink over time. Not perfect, expensive, and complicated. It would be great to have better biomarkers, and that's what Dr. Kurana was mentioning, which is one of the biggest difficulties in designing clinical trials, is how do you measure the change? Because if you have 10,000 patients, it's easy to see difference, right? Because the strength in numbers. But when you have 100 patients, it's very difficult to see differences with placebo in 1 year, unless we would have some fantastic marker. I hope he's going to give us one. I hope that by looking at how that process occurs, maybe there is some biochemical change. Maybe there is another change, maybe the synuclein burden. Maybe there are other ways. We hope some basic scientists are going to give us biomarkers.
No pressure, Dr. Kurana.
No pressure. No pressure. Yeah.
I would just say that all of the ways the things you've mentioned and are all very promising, but just as you've just heard, I think the biggest challenge here is coordinating efforts. And I think we've heard that I think it's been a theme throughout, that we need to have different centers within the United States. I think the moves that we've heard about today are just fantastic in terms of standardizing the information that we get in a clinical appointment, coordinating that with biomarkers, information that we can get from blood and CSF. We coordinate that with information that we're getting from stem cells as they grow in a dish. We need to do that in a systematic way. It needs to be standardized. Otherwise, it doesn't matter how intriguing something is, it's not going to give us an answer.
So that's why the name is MSA Coalition, right? It's easy to get all together. Our group is called a consortium, and the idea would be that we will all be together. And let's hope that this meeting will also be part of that, right? To get more centers together, because as the Three Musketeers said, right? Okay.
So since we're in the basic science discussion, do you want to answer some of your questions?
Okay, I'll try and answer them quickly because I know there are a number of questions. One question was, is there a connection between a glial cell inclusion and gliadin protein or gliadin protein that's been implicated in gluten enteropathies or celiac disease? And the answer to that is unfortunately it's just a misnomer. It's a poorly chosen name. There's no relationship. Okay, so a glial cell, that's an old word for glue. Those cells were not thought to be so important, but it turns out our brain is full of these cells, and we all know they're very important. And that has nothing to do with the gliadin that you've heard of that you get antibodies to in gluten sensitivities. Someone has asked whether stem cell trials, are they? I've heard that they're not promising. What alternative research is promising for MSA? And I would just say it's really early days. I wouldn't give up any hope on stem cell treatments or the things that we can do with stem cells or in using them for screening for drugs. So hopefully I've outlined a few different avenues today, and I think that they're promising. I think that we just need to do a lot more work. So just because things have been reported negative or positive, it doesn't really, shouldn't really detract or over-encourage us in any particular direction. I think really my message is that we need to do this more thoroughly. There was a question about whether patients with MSA have undergone deep brain stimulation. I don't know of the systematic data for that. I would think that for MSA, as opposed to Parkinson's disease, the neuroanatomical basis of that, as I was showing in my slides, is much more complex and widespread. And so I think the idea that just by activating a single neural circuit, you will improve the quality of life of a patient, even if you were to improve some measure of neurologic function, I think that kind of approach is probably limited because of the widespread nature of the disease, and because there's degeneration not just in those dopamine neurons, but also in the neurons that receive the messages from those dopamine neurons in MSA, and I think that's a critical difference between the diseases. And I think that's pretty good for now.
Okay. All right, thank you. And we have a few questions on compression stockings here that maybe the one you have, Horatio, can summarize.
So there is one question here. Can compression socks or stockings help swollen feet or ankles? And are there any specific causes for swollen feet? I will start with the last one. The swollen feet are very common in people with MSA, also in people that do not walk. The swollen feet are mostly because of lack of walking and the activity of the muscle pump. It's not heart failure that people with heart failure can have very swollen legs. In the case of MSA, most of the times it's just that they are not walking or moving enough. So the stockings alone can help, but will not do it. The important thing is to move and walk and to compress the muscles or to raise the legs. Sometimes the swollen feet or ankles are the price you pay for volume expansion, though. If you take a lot of salt and water and Florinef, your feet will get a little bit swollen, and we may have to tolerate that in order to maintain the pressure high, right? But if they are too swollen, you have to raise them up and move more, right? I don't know if I answered that.
We also have a question about something that you mentioned in your talk, Horacio. The people who get up multiple times at night and they cannot handle the bladder issues. So what would be the ideal scenario for them? How would they manage that part?
One of the ideal scenarios is to try to reduce the blood pressure during the night in the hope that then urine production during the night is going to be reduced, like I showed you, with the blood pressure. Sometimes that alone doesn't do it, and there are a number, not just for the night, but there are a number of treatments to try to reduce the frequency. Some patients use self-catheterization, and sometimes is the only option to self-catheterize 2 or 3 times a day, and then using drugs like anticholinergics that prevent the contraction of the bladder. So as long as you empty the bladder with a catheter 2 or 3 times a day, then you can either use Botox directly in the bladder or anticholinergics. The issue, of course, is that you may not be able to urinate alone anymore. But at least it would improve your ability to function because you know that you don't have to run to the bathroom every 3 minutes. So a lot of patients opt for self-catheterization twice a day, and that allows them for a much normal life. Other alternative is suprapubic catheters that some patients use in a permanent way.
Thank you. Is there anybody in the audience? Yes, please go ahead. Sure, go ahead.
I don't know if you would think that that's good for most people or not, but that's just from my experience what works for me. It gives me a better quality of life because getting up that many times during the night and the broken sleep was not very good.
Sure. No, that's definitely, Mr. Zimmerman, one way of doing it. The other is, instead of using, but I'm sure you try this, instead of using an indwelling catheter, you can use a Texas one, an outside one, during the night. But if you are used to the indwelling catheter and that works, that's a good solution.
I live in outback Australia, more or less outback Australia, and I've never ever come face to face with a person with MSA before, apart from my husband. I've spoken to several through the internet, but what I'm finding is that MSA affects everybody in a different way. My husband has terrible trouble with his eyes, and one of you just said that it doesn't affect the eyes. And fatigue is his major concern.
Fatigue.
Yeah. He is just so exhausted all of the time. He does walk quite a bit, but other than that, he's just absolutely exhausted. I don't think I've met anybody else here who quite suffers in those 2 ways. In many ways, he is, I feel, he is better than he was when he was diagnosed in some areas, but these are the 2 areas that he's really bad in. But the other thing that concerns me is that nobody talks about diet, and all of us are suffering from not having any medication to cure this disease or even to do anything but simply treat any symptoms with drugs. And the only thing that we've had any success with at all is diet. And I think it plays a major role. Until a cure is found, that's pretty much all we've got. And I don't know, the medical profession don't seem to look at the whole body. They seem to look at the symptoms, and diet to me is probably the most important thing that we can do as carers and sufferers.
So I mean, I have a comment to that. I mean, in terms of looking at patients as a whole, I think that's critically important. I think that and I have a question here about about EGCG, which is a component of green tea. So someone's asking me something similar in terms of in terms of supplementing the diet or whether that can affect the disease progression. So I think diet is important. I would say of the most validated lifestyle changes that we know in neurodegenerative diseases, aerobic exercise is the one that has been validated the most. So if you're thinking about things that we're not going to design clinical trials for because people aren't going to make a lot of money out of a drug, and you're thinking about lifestyle changes, and I think it's come up in talks today, aerobic exercise, recumbent bikes, things that are safe, things that actually boost the heart rate a few times a week in a variety of animal models and in diseases which are common enough to study them, like Parkinson's disease, where you can do systematic studies. Virtually all of those studies have turned out to show benefit in aerobic exercise. The question of diet is much more complicated because, especially in a rare disease, it's not that people don't think it's important, and the total number of calories you take per day could also be critically important for progression of disease. It's just that we don't have the data on it. So it's very difficult to give recommendations when there isn't the kind of systematic studies that we have in other ways. So that's part of the complexity. I don't think anyone's saying it's not important. I think we like to give advice when we really think that there's solid data that something is going to make a positive difference to a patient. And that's why, again, it comes back to the same theme. We need to be consortia and coalitions and study this systematically so we can think about some of those, what's called in general, epidemiologic factors that may be critical for disease progression.
I think you just answered that question.
Lucy, do you have any questions for you that you'd like to answer among the stack?
I can ask them.
Yes.
So we have one question that came in through just now about what is a neuroprotective diet and is it beneficial in treating symptoms of MSA, which I think Dr. Khurana just answered right now. And then we have another one of which I'm going to pose to Dr. Kaufman, which is what is the nature of the meeting next month in Las Vegas?
Okay, what happens in Vegas stays in Vegas, right? So this is called the roadmap, and it has sort of a long story because there's a person that is a famous chef and developed MSA, so he put a lot of his friends together and raised a lot of money and got a young doctor there's a branch of the Cleveland Clinic in Las Vegas, and they put together this thing called the roadmap for MSA. This grew to be, now it's going to be a big meeting with working groups from people from all over the world, and the idea is only a day and a half, but the idea is to provide recommendations of the same type of things we are talking about here. One of the working groups is for biomarkers, so I can tell you now, even if you don't go, that the outcome of that meeting is going to be that we need biomarkers. That's number one. The outcome of that meeting is that we do need a registry, and it's important to have a registry. Then there's another working group on animal models or preclinical. Essentially, it will be a way to put a lot of people together working on MSA. NIH is also on board, and they are part of the organization of the meeting. The patient advocacy groups like the MSA Coalition is also going to be part of that. Industry is going to be part of that. So let's hope that it's going to be a way to produce more momentum for MSA and for many of us that have been working on this disease for more than 30 years, and it was very difficult to get anybody interested. The fact that now we are having a critical mass and that a lot of people are interested and that there's even a meeting in Las Vegas for MSA, something it would have been unheard. 20 years ago, MSA was, or 25 years ago, in fact, when we wrote the criteria for diagnosis, The most important thing about MSA, and don't take this badly, but the most important thing was to make sure that those patients were identified so that they would not be in the Parkinson's trials. You know, the Parkinson's disease had many trials, and to make certain that the trials were done properly, it was very important to exclude people with MSA. That was the main interest about MSA, how to get rid of them. And I think that it has changed, fortunately, dramatically now, and brings MSA to center stage, not just like the little brother of Parkinson's, but a disease in and of itself that deserves its own trials and its own research. And I think that what you see today is an example of that. So I don't know if I answer the question, what's the Las Vegas meeting, but that's what it is, right?
Okay. I just want to say we're going to answer a couple more questions, but I think Dr. Khurana really has to get out of here to catch a plane. I think his taxi's probably out there, limo, whatever, is probably out there idling and waiting for him. So I wanted to give him permission to go on and leave the speaker's area, and just thank you so much for coming.
Thank you. It's a real privilege to be here. Thank you so much.
And we'll answer a couple more questions, but if we want to have time for the breakout sessions, in about 10 minutes, we're going to have to cut the questions off. So.
Okay, so in the 10 minutes that we have, let me answer this question here. This is a question about whether we can consider MSA an autonomic neuropathy. So, well, the quick answer is that it is not what we generally find as an autonomic neuropathy, because we think that the problem is central. All right, so it's coming from a problem in the brain. Now, however, having said that, it seems that there are some elements in MSA that suggest that there might be an autonomic neuropathy component going on with it. So, for example, we saw that people who have skin biopsies in MSA have lost some of those small fibers, exactly the same way as, for example, a diabetic patient would have. So the question is whether there is a component of autonomic neuropathy. Is it primary? Is it secondary? So this we do not know exactly yet. But generally, we don't put it in the category of an autonomic neuropathy. A question about headaches, chronic headaches in MSA, and I'll take your question after that. You know, headaches, migraines in particular, many of the current thinkers about this topic think about it as being an autonomic problem. So it is not unusual to have chronic headaches or chronic migraines in people who have autonomic disorders. So I would put that in this category. I'm not aware of a special mechanism particular to MSA. Do you know anything, Horacio, about that? For headaches. All right, so probably if we want to say that this is a generalized autonomic problem, and one of the manifestations would be headaches as well. I'll leave that last question till the end, I think it's very important. You have a question on droxidopa, I think.
Yes. You know, one, you just remind me about headaches. You know, one that we found interesting is, you know, a very common side effect of Florinef is headaches. In fact, that was one of the main reasons that the astronauts to whom we give Florinef, or we used to, don't want to take it, many of them. So occasionally these headaches are because of the Florinef. That's one thing to consider. And sometimes there is a direct relationship with blood pressure, like Kemal just mentioned. Then the question is whether droxidopa can replace Florinef and midodrine, or is it in addition, right? That's the question. So, look, potentially, we may be able to, I mean, theoretically, one can think that combining, let's say, midodrine and Florinef midodrine and droxidopa, both vasoconstrictors, could potentially be useful. We don't have the data because in all the clinical studies, when people took droxidopa, we asked them to stop the midodrine because there are two vasoconstrictors, and that was what we did for the clinical trials, but we never compare one to the other, nor we try them together. But potentially, there is a possibility of using it together, meaning midodrine and droxidopa. Regarding Florinef, most of the times they are used together, and the idea is to use as little Florinef as you need, if you cannot completely withdraw it, to take maybe half a pill a day or just one pill a day, 0.1 milligrams, as little as you can, and combine that with droxidopa. That's the way we did it in the clinical trials. We hope that many of these questions, we are going to be able to answer them better now that the drug is available and that we can really all get more clinical experience, not just in a very structured clinical trial, but in the real life of every day with patients and see how they can be combined better.
Great. Is there anything else that you would like to answer?
We have one question that is again directed to Dr. Kaufman as to where can people find the information that you gave in your presentation on the non-pharmacological treatments for neurogenic orthostatic hypotension.
Okay. Several of these things are published, and if anybody is interested, just call us at NYU and we'll send you a whole thing on how to do things. And in fact, we hope to put all this in the web, and we will.
In the American Autonomic Society, we just redid our website as a big project, and we're creating and developing a patient education series in which we're going to put a lot of the non-pharmacological measures spelt out and to provide a resource for patients and physicians to be able to go there to find this advice.
Let me just add something to that. If you haven't already looked through the purpley blue binders that we gave you, there's a 57-page document in there, MSA, what you need to know, and there's a bunch of, I think virtually all the non-pharmacological treatments that are covered in there, as well as some pharmacological ones. So when you have a minute, I know it's been a power-packed 24 hours or so, but when you have a minute to flip through there, that may answer a lot of your questions. And that same document is available in a PDF form on the MSA Coalition website.
Well, I think at this point, before we conclude, I would like to take the question. Sure. Sorry, we made you wait a long time. Go ahead.
In patients with MSA type P, how frequently do you see severe lower back pain that radiates around the obliques, due primarily to muscle spasms and muscle rigidity? And then what treatment courses do you recommend for that, both from the muscle spasm perspective and the pain perspective?
I cannot tell that I've really seen this scenario before. I mean, we know that in Parkinsonism there is muscle pain that is associated with it. I don't think we've used anything other than muscle relaxants or just pain medications. That would be my answer to that. I don't know if you have any other.
Pain is a dramatic problem in Parkinson's disease, despite the fact that in theory it's not a feature of Parkinson's, but the reality is that a lot of patients do have different pain syndromes. And in MSA, some patients, I didn't hear all your question, but in some people with MSA have, for example, severe pain in the legs, and it's a constant pain in the legs, which is not fully similar to, let's say, what Dr. Cemali described in small fiber neuropathy. We wonder whether this is ischemic pain, which is similar to the one in the neck, but there are some patients that's one of the worst problems. And But we did all sorts of studies, and we don't have very good treatments. It seems that, I mean, what Chemali told you, and then exercise, muscle relaxants, and try to improve blood pressure control, but it still remains a huge problem.
This morning, Dr. Thomas mentioned various alternative treatments and therapies. She didn't mention green tea extract or ECGC, and Dr. Khurana mentioned it or alluded to it briefly before he left, but didn't really address the issue. And I know that there are clinical trials going on now that are considering its benefit for MSA patients. And there are various ones relating it to its benefits for patients with cancer, et cetera. Do you guys have any comments on possibly taking it as a supplemental non-pharmaceutical medication?
Look, I'm going to take the short answer is that we don't have the data. So we don't know. I can tell you that at NYU, also, we don't take care only of MSA, but we also take care of a genetic disease called familial dysautonomia, which is a gene mutation of a gene that produces a protein called ICAP. So for many of these patients, and there are around 360 of them that come to the center, many of them for a number of years took green tea and tocotrienols with the idea that this would modify or improve what's called a splicing defect in this disease. Unfortunately, they did not work. But other compounds that are also diet-based, one is called kinetin and the other one is called phosphatidylserine, they do improve, at least in blood, the level of this deficient protein, ICAP. We still don't know whether that's going to improve the disease, but it does improve the level of the protein. So in theory, some of these food supplements or other compounds may have a direct effect on genetic abnormalities. There's nothing known about that in MSA, but it's certainly something to look at.
Okay, so this being said, now I think we spoke enough as speakers. I want to thank the speakers for their contributions, and I would like to finish, but we have 5 minutes for that, maybe on a positive note, something that would be uplifting for the rest of the group. And I have a question that may allow us to do that, okay? So we were not going to speak forever, so I really would like somebody who has had a personal experience with this issue to stand up and to give us their experience, maximum 2 people, and then we will close after that. So the question is, as a caregiver or family, how do we handle our MSA loved one who has seemed to give up or be depressed? We have
Hang on just a minute.
Hello. My husband, Mark, died 2 years ago of MSA. Very active, never ill, and he kept saying to me, I'm a goner, this is it. And I would hit him with a sock. And I would say, choose life. And that's my philosophy. It continues to be now. We surrounded ourselves by friends, family. We continued life as normally as possible. We went out to social events. We traveled. I carried the suitcases. Until he stopped driving, we drove places. We never let the illness dictate our life. We dictated our life. The medicines did not help him much. In fact, I think he was over-medicated, and I think that's a danger in MSA with doctors who are not familiar with it or have never treated it, and everybody was flinging medicine at him. And we didn't let that stop us, and I think that that's the way to do it. You have to choose life. You have to express your emotions. You have to feel sadness or concern or what am I doing to you? And don't, as a caregiver too, I would say, don't be afraid to say that you're tired. Don't be afraid to ask for help. Don't be afraid to tell your loved one that you're killing me, but I love you and I'll do it. And I don't know what else to say. Nobody responds the same to illness in a family, okay? But I can tell you that for me, keeping it as normal as possible, telling people the truth about what my husband had, who people never heard of it. I never heard of it. He never heard of it. The neurologist that we went to initially had only treated 3 patients with it, for God's sakes. And so it's up to you as the caregiver to be the cheerleader for your patient, to let him know you love him, you'll do whatever is necessary, you will buy whatever is necessary, you will get whatever is necessary, but you will also live and give him the quality of life that you had enjoyed up to the time that he was not able to do everything. And that's really all I can share, but it helped. It was hard and it was heartbreaking, but it helped. So that's it.
I'm not sure we can top that, but I think there's somebody here who's going to give it a try.
I'm not sure if this will help either. I talked to one caregiver, Angela, that we met last year and told her what we've been able to have some success with. And one of those, when you start this process and those symptoms first begin, that's where really probably the hardest time is for the patient, because you don't know what's going on. Your caregiver doesn't know what's going on. No amount of research seems to get the answer. And what we found was we were referred to a counselor, a very nice lady. She has her master's degree in counseling. She has seen the 2 of us or either one of us almost every week for the last 5 years. And when we have issues that we both need to have addressed together, she's able to sit down with us and help us understand which one of us needs to do the talking, which one of us needs to do the listening, where there is some common ground. We can leave, and we have tools that are available to us for that next week or the next month or whatever. And I would not say we would be in a worse place if we had not had that that counselor. But we have found counseling on a regular basis to be a very powerful tool to help give us what we can use to make it better for us. So maybe counseling, and it seems like we did some checking, it seems like insurance companies are willing to pay for counseling, especially for depression and the types of diseases that would lead to that. So maybe that's something you could look into as well, and it does seem to be a very powerful tool for us.
So we should try to get FDA approval for that sock that you were using for your husband. That may be the secret, right? And then before you say, let me just say, yes, that may come. You should all know that Dr. Cemali is a very accomplished concert pianist. So for the next meeting, he should also play. That would be uplifting, right?
Thank you, but hold your applause until after you hear me. Maybe, maybe you won't like it.
Are you going to be in Vegas?
It's not in my plans.
He has Liberace's piano.
I play classical music. I don't know if Vegas is a place for that.
So, well, I think we're going to close on that happy note, and thank you too for sharing. We are going to still have, for the next 20 minutes or so, the patient-caregiver breakouts. Again, thank you to the panel. You guys were super. Thank you for taking all the time to answer the questions. But also thank all of you for coming, because without your attendance, we would not have a conference. And we from 3 years ago, we've literally doubled the size of our conference, and that is so heartwarming to us, and to see so many people returning. And on that note, if you have not filled out your evaluation, please do. We hope it's all, 20s on a scale of 1 to 10, we've got 20s. But we know that that's not practical. We know that there are things that we could do better, including having a warmer room. But we didn't want everybody to just start sweating either. So, but do be very honest on those evaluations. That is the only way that we can judge how well we did or how poorly we did or what we need to do to make next year better. And we hope that you will watch our website and sign up early for next year. We're not sure where it's going to be, but we hope to announce that very soon so people can look forward to it and make plans. Again, thank you all, and thank you.